For this next presentation, we're going to be going over the next requirements for training, which is on shaken baby syndrome, safe sleep practices, SIDS, and early brain development. The roadmap or our agenda will be that we will do an introduction, and we will go over part 1, which is shaken baby syndrome, part 2, safe sleep practices, part 3, sudden infant deaths, or commonly known as SIDS, part 4, early brain development, and the final is reflection and evaluation. I would like to share the Texas Human Resource Code, Chapter 42, Section 420421, B and C. This code clearly states that employees of licensed daycare centers, group daycare homes, and registered family homes providing daycare for children under 24 months must receive 1 hour of annual in-service training on recognizing and preventing shaken baby syndrome, safe sleep practices, preventing infant death syndrome, and understanding early brain development. As employees of Niños who serve both Early Head Start and Head Start, we have placed training requirements of all our employees. The objectives for this training are as follows. First, you will be able to describe key terms such as shaken baby syndrome and sudden infant death. You will also be able to name at least 4 recommended safe sleep practices. You will be able to name at least 4 signs or symptoms of a baby or young child might display if shaken baby syndrome has occurred. And you will name at least 4 things that can be done to reduce sudden infant death, or SIDS. And you will be able to name 4 things to do positively to affect a baby's brain development. Now here's our first key term, shaken baby syndrome, a definition. Shaken baby syndrome is a term used to describe brain injury to young children under 3 years of age, most commonly under 18 months, resulting from vigorous shaking of an infant or child by arms, legs, or shoulders. So there again, here is your first term. Shaken baby syndrome is a term used to describe brain injury in young children under 3 years of age, resulting from vigorous shaking of an infant or child by arms, legs, or shoulders. Shaken baby syndrome is considered to be a form of child abuse. And if you believe that any child, your child or any child, has been subjected to any abuse, please report to Child Protective Services. Now let's look at some common knowledge, signs, and symptoms of shaken baby syndrome. First, there are various signs and symptoms of shaken baby syndrome. The consequences of less severe cases may not be brought to the attention of medical professionals and may never be diagnosed. In most severe cases, however, which usually may result in death or severe neurological consequences, the child usually becomes immediately unconscious and suffers rapidly escalating life-threatening central nervous system dysfunctions. Common symptoms of shaken baby syndrome include decreased muscle tone, extreme irritability, decreased appetite, poor feeding or vomiting for no apparent reason, no smiling or vocalization, poor sucking or swallowing, rigidity or posturing, difficulty breathing, seizures, head or forehead appear usually larger than usual, or a soft spot of the head appears to be bulging, the inability to lift head, the inability of eyes to focus or track movement, or unequal size of pupils. Now we'll go over some of these again in the next few slides. What happens? Well, when the baby is shaken severely, the brain rotates within the skull cavity, injuring or destroying brain tissue. When the shaking occurs, blood vessels feeding the brain can be torn, leading to bleeding around the brain. Blood pools within the skull sometimes creates more pressure within the skull and possibly causing additional brain damage. Retinal bleeding is also very common. So again, some of the immediate consequences again include breathing may stop or may be compromised, extreme irritability, seizures, limp arms and legs, decreased levels of consciousness, vomiting, poor feeding, inability to suck or swallow, your heart may stop, and unfortunately, it can lead to death. If an infant does recover from shaken baby syndrome, it still can lead to long-term consequences, such as learning disabilities, physical disabilities, visual disabilities or blindness, hearing impairment, speech disabilities, cerebral palsy, seizures, behavior disorders, or cognitive impairment. Why and when? Babies' heads are relatively large and heavy, making up about 25% of their total weight. Their neck muscles are too weak to support such a disproportionately large head. That's why we always put our hands behind their head when carrying a young infant to support their neck. Babies' brains are immature and more easily injured by shaking. Babies' blood vessels around the brain are more susceptible to tearing than older children or adults. Often, perpetrators shaking an infant or child out of frustration or anger. This most often occurs when the baby won't stop crying. Other triggering events include toilet training difficulties and feeding problems. Let's take a look at a brief video clip on shaken baby syndrome.
Babies cry. Sometimes they cry a lot. So much you may feel like you can't take it anymore. We need to remember crying is a baby's way of communicating, and it's normal. Babies have different cries, and sometimes it's hard to tell what they want. The baby may be hungry, too hot, too cold, need a diaper change, have a tummy ache, or just want to be held. and sometimes babies just cry, and there is nothing you can do about it. It is okay to let your baby cry. This doesn't mean you are a bad parent. It's also normal that you might feel overwhelmed or frustrated. A baby won't die from crying, but they can die from being shaken. Did you know that nonstop crying is a primary trigger for shaking a baby? Before you lose it, stop. Put your baby down someplace safe and walk away. It's okay to take a break. Whatever you do, never shake a baby. Abusive head trauma, also known as shaken baby syndrome, occurs when a caregiver becomes frustrated and shakes the baby to stop the crying. Compared to the rest of their body, babies have large heads and weak neck muscles. When shaken, the baby's head moves back and forth, whiplashing the brain against the skull, causing bruising, bleeding, and swelling inside the brain. Abusive head trauma can lead to blindness, hearing loss, speech or learning disabilities, seizures, brain damage, cerebral palsy, and too often, death. Some babies may seem okay at first, but still have serious brain injuries that you can't see, causing them to have trouble learning, following directions, or making friends later in life. Signs of abusive head trauma may include trouble breathing, excessive crankiness, seizures, vomiting, limp arms and legs, difficulty staying awake, or unresponsiveness. If you think your baby could have been shaken, call 911. Crying happens. Stay calm. Making a plan now on how you're going to deal with it can make all the difference. There are 3 steps to a crying plan, and all you have to remember is CRY. C. Choose a calming technique. Swaddle the baby. Hold the baby close. Turn on some white noise, a soft, continual rhythmic sound like a fan or a vacuum cleaner. Offer a pacifier. Sing. Talk softly to the baby or use a shushing noise. Gently rock the baby or use an infant swing. Put the baby in a car seat and take a drive, or take the baby outside for a walk in the stroller. R. Choose a relief method. Take a break. Put the baby in a safe place. Close the door and walk away. Check baby every few minutes until you are calm. Do some deep breathing. Listen to music or exercise. Call someone to come over and give you a break, or just to talk for a while. Why? Discuss your crying plan with everyone who might care for your baby. Tell them what you know about babies and crying. Show them your crying plan, then ask them what they will do if they start to become frustrated and how they plan to cope. Remind them to lay the baby down in a safe place and call you if they start to feel themselves becoming upset. This can make a life-changing difference for you and your baby. Abusive head trauma is 100% preventable. No matter how tired, angry, or frustrated you feel, you must never shake a baby. Share your crying plan with everyone who will care for your child as often as it takes. If you need help, call the Nebraska Family Helpline at 1-888-866-8660. Raising kids is hard. It's okay to ask for advice. Take a break. Never shake.
Part 2. Safe Sleep Practices. Key to Infant Safety. Since 2002, over 70% of infant deaths in licensed child care, which include early Head Start, occurred when the infant was in an unsafe sleep arrangement. However, after 2013 implementation of new standards and training requirements for safe sleep practices, deaths in licensed child care, again including early Head Start, have decreased significantly. This decrease is attributed to enhanced infant safe sleep standards and training requirements, heightened awareness of safety issues, and publicity surrounding non-compliance resulting in infant deaths. The trend now for safe sleep practices is back to sleep for every sleep. To reduce the risk of SIDS and suffocation, back sleeping for every sleep. What that means is that when we put the babies to sleep, they need to be placed on their back. Side sleeping is not safe and not advised. I remember when they used to have special pillows that you could place on them so that they could lay on their side when they wanted to sleep on their stomach, but that's no longer advised. And supervised tummy time occurs only when the babies are awake. Now there's many reasons that people or parents place babies on their stomach. These are the 4 leading beliefs. When the baby is sleeping on their back, he or she startles more easily and wakes up. When the baby will get a flat head if the baby sleeps on his back. The baby will have a bald spot from sleeping on the back. When babies sleep on their back, they don't develop normally. But what we have to remember is the autonomy. What occurs when the children sleep on their backs, their trachea and their esophagus are opened to inhaling air. Where when they're laying on their stomach, you're enclosing the esophagus and their trachea. Recommended safe sleep practices include that infants must be placed on their back to sleep unless there is a physician's directive for anything other than back sleeping position. If an infant falls asleep before being placed in a crib, the provider must move the infant to the crib as soon as practical. An infant who independently rolls over onto its stomach after being placed to sleep on its back may be allowed to remain sleeping on its stomach if the infant is at least 6 months old or the provider has a signed statement from the parent indicating that the infant regularly rolls over at home. Nothing is allowed in the crib with the infant except a pacifier, and that is only if needed. Mattresses must be firm and crib sheets must be tight-fitting. No soft bedding. A center staff person must be within sight and hearing of children at all times and capable of intervening to protect the health and safety of children. Now, many of you say, well, how do I handle parents' concerns who want their baby to sleep on their stomach? You say, a lot of parents want to place their baby on their stomach for sleep because that's what they do at home. How do I handle this? First, it is important for you to discuss sudden infant death syndrome with parents so that they understand why you place infants on their back. Discuss the sleep position policies and regulations mandated by your program by state and federal guidelines. Discuss the need to have a medical waiver and implications of that. And also document your discussion. Document that you have discussed this with parents as to why you have the need to place the baby on his back to sleep. Safe sleep practices. The key to infant safety is sleep on their back. Now we are in part 3 of our discussion. Sudden infant death syndrome, understanding and action. Sudden infant death syndrome, SIDS, remains a leading cause of death for infants in Texas. Metropolitan areas see the largest concentration of death. However, all communities are at some time affected by a SIDS death. Knowledge of SIDS facts, learning the steps to take to reduce the risk of SIDS, and implementing a plan of action to deal with sudden death of an infant will promote a comprehensive community response to SIDS. When does it occur? Sudden infant death syndrome is a diagnosis given for the sudden infant death of an infant from 1 month to 1 year of age. It has been found that 91% of SIDS deaths occur before the age of 6 months, with the highest concentration occurring between 2 months and 4 months of age. Interesting is the increased incidence occur during the winter months. Who does SIDS affect? SIDS affects all races and socioeconomic groups, although more common with male children. While environmental, behavioral, and physical influences may put some infants at greater risk for SIDS, and conversely many SIDS victims meet no risk factors. SIDS is recognized as a medical disorder. Infants who succumb to syndrome appear healthy before the incident, even to the physician. SIDS appears to occur after an infant has been put for sleep. Victims may have been down for sleep for as little as 10 minutes. There is no apparent sign of the infant struggling or suffering. Though SIDS is associated with an infant's sleep time and often occurs in the crib, the event may occur anywhere the infant is sleeping. And unfortunately, the first and only symptom is death. Years of evaluation have revealed what SIDS is not. SIDS is not hereditary. SIDS is not contagious. SIDS is not caused by immunization. SIDS is not choking. SIDS is not apnea. SIDS is not suffocation. And SIDS is not child abuse. There are some risk factors. We find that SIDS occurs to infants whose mothers are less than 20 years of age. It occurs to infants whose mothers receive late or no prenatal care. It occurs commonly to premature infants or low birth weight infants. It occurs commonly to mothers who had drug or alcohol use during pregnancy, or to mothers who were smoking. Mothers who smoke during and after pregnancy triple the risk to infants of SIDS. To reduce the risk of SIDS, it is recommended that, of course, healthy babies should be placed back for sleep. Babies should sleep on a firm, flat surface with no soft bedding, pillows, sheepskin, or stuffed toys in the crib. That mothers should get prenatal and postnatal care. That we avoid overheating the baby while going to sleep. That you do not smoke while pregnant or allow anyone else to smoke around the baby. And breastfeeding is highly recommended if possible. There are many SIDS support groups. Just looking online, I picked the first 3 that I found. There's one in North Texas, it's North Texas SIDS Alliance. There's a SIDS support for San Antonio. And there's a Parkland SIDS Center. But all you have to do to find support is look for it online or a website, and you will find lots of support on sudden infant death syndrome. Let's watch a brief video clip on sudden infant death syndrome.
Sudden infant death syndrome, or SIDS, which is also known as cot death or crib death, is the sudden and unexplainable death of an infant during their first year of life. Because of the seemingly random nature of this condition, there are a number of risk factors that seem to correlate with getting SIDS, but there's no clear mechanism or cause that's been identified. SIDS is considered a diagnosis of exclusion, meaning all other causes have to be ruled out before an infant death is given that label. The most well-known risk factors have to do with how an infant sleeps. To lower the risk of SIDS, the recommendation is to make sure that babies sleep alone in a crib, on their backs, and without blankets. The risk of SIDS is higher among boys rather than girls, as well as infants between 2 and 4 months old, and among formula-fed babies, and those born prematurely or with low birth weight. Risk factors that relate to a mother include receiving little or no prenatal care, being a teenage mother, and smoking during the pregnancy. Alcohol consumption is also thought to be a risk factor because there are more cases of SIDS during weekends, the New Year, and other times of the year when drinking is included in celebrations. The fact that far more boys die of SIDS than girls shows that there is a level of genetic susceptibility at play, but the exact specifics are unclear. A minority of SIDS-related deaths show a correlation with genetically inherited channelopathies, which are defects in ion channels that affect a variety of tissues, including the heart. Another possible genetic link is the higher incidence of SIDS in babies with gene mutations involved in the autonomic nervous system. These clues, though, are still being researched, and no exact gene or combination of genetic defects has been identified. SIDS is generally thought to happen in children that have a genetic susceptibility which is then triggered by external factors. An epidemiologic clue is that Native American infants have the highest rates of SIDS, while Asian infants have the lowest rates of SIDS. Cultural practices around sleep, though, might also play a role, and so it makes it hard to tease apart genetic and environmental factors when it comes to race. A diagnosis of SIDS can only be made following an autopsy, to make sure that there isn't an alternative explanation for an infant's death. For prevention, unfortunately, because the underlying cause of SIDS is usually unknown, there's no surefire way to prevent it. Alright, as a quick recap, sudden infant death syndrome, or SIDS, is a diagnosis of exclusion given to an infant that dies of unknown causes, and is most common in infant boys between 2 and 4 months of age, but can happen any time in the first year of life. To minimize the risk of SIDS, infants should be put to sleep on their back, should not be exposed to cigarette smoke, and should be breastfed if possible. What's going on, guys? Thanks for watching. Hope you found that video informative. Don't have too many updates for you besides, I guess, tell you that I'm excited that we're going to VidCon. That'll be really fun. I went last year and it was a blast, and just bought my tickets. So pretty exciting. Hopefully we'll see some of you guys there. Besides that, special thanks goes to Fergus for writing the script, as well as Rishi and Kyle for editing the script. Oh, and also, if you guys want to quiz yourself on this material or other videos that we have, you should head over to osmosis.org. There's a bunch of quiz questions and flashcards and a ton of other stuff that, is really awesome. So if you got time, check that out. If not, you can always subscribe to our channel or support us on Patreon, and follow us on social media. Thanks, guys. Bye.
Now we are at our final part of our presentation, which is early brain development. And today I'm going to share 3 core concepts about early brain development. First, we need to remember that brain architecture is established early in life and supports lifelong learning, behaviors, and health. And what I want to emphasize here is that it can be either positive or it can be negative. So it is up to us to make sure that the lifelong learning, behavior, and health is supported in a positive manner. Stable and caring relationships and serve and return interactions shape brain architecture. This is why we emphasize teacher-child interactions, engagement, relationships with children. Okay, it's what shapes the brain architecture. Toxic stress in early years of life can derail healthy development. And I want to stress this enough. I can't stress this enough. That toxic stress is very related to emotional abuse. So again, brain architecture is established early in life and supports lifelong learning, behavior, and health, stable caring conditions, and serve and return interactions shape brain architecture. And toxic stress in early years of life can derail healthy development. What we know is that we are part of shaping the future. Early experiences shape brain architecture. Through developmental milestones, we know that simple skills come first and the more complex skills build on top of them. A strong foundation in the early years improves the odds for positive outcomes, and a weak foundation increases the odds of problems later in life. Let me talk a little bit about toxic stress. Learning how to cope with moderate, short-lived stress can build a healthy stress response system. So what we're saying here is that it's okay to have stress in your life and learn how to build on it and learn how to cope with it, because it builds a healthy stress response system. However, if it is overemphasized, that there is too much toxic stress, when the body stress report system is activated extensively, then it can weaken your brain architecture. Because what happens is that your brain is trying to block out that stress, and therefore not making those connections. Without caring adults to buffer children, toxic stress can have long-term consequences for learning, behavior, and both physical and mental health. Our goal in Early Head Start and in Head Start is for children to gain a healthy brain development. For this, children need a balanced approach to emotional, social, cognitive, language, and physical development, starting in the earliest years of life. Children also need supportive relationships and positive learning experiences that begin with their parents, but are strengthened by others such as yourself outside the home. Children also need highly specialized interventions as early as possible for children and families who are experiencing significant adversity. To maximize healthy brain development, we need to consider children's learning styles and their temperament. There are three basic learning styles. You have your visual learners who learn through seeing. You have the auditory learners who learn through listening. And then you have the tactile or the kinesthetic learners that learn through moving, doing, and touching. Visual learners need to see the teacher's body language and facial expressions to fully understand the content of the lesson. That's why we say that when you're teaching children, that you need to make sure that all children are seeing you and that you have eye contact with each child. These visual learners tend to prefer sitting at the front or very close to the teacher to avoid any visual obstructions. They think and learn better in pictures and learn best from visual displays, such as KWL charts, posters, large books, anything that flip charts, anything that they are able to see. While auditory learners learn best through discussions, talking things through, listening to what others have to say. Written information has little meaning until it is heard. These learners best learn from read-alouds and from recordings and music. So where your visual learners see best in seeing things, such as books, auditory learners that learn through listening learn better from hearing you read. But most commonly, Very young children are tactile or kinesthetic learners. They learn through moving, doing, and touching. These learn best through a hands-on approach, actively exploring the physical world around them. They find it hard to sit for long periods and may become easily distracted by their need for activity and explorations. So therefore, as you're reading, you want to make sure that you are reading a book to them. You want to include some type of movement or something that they're doing as you're reading along. Scientists have identified specific behavior that is part of each person's temperament. These are called temperament traits. Whether a child is basically happy or serious, active or inactive, these are traits that make them unique individuals that they are. Everyone fits somewhere in all the traits of temperament categories. The traits of temperament are activity level, strength of expression, ability to change, sensitivity to senses, persistence, need for physical routine, awareness of feelings, distractibility, usual mood. When considering the activity level, you need to ask yourself, does this child seem to always be moving or usually sitting still? A child who is very active needs an outlet for his energy and will not be able to sit still or quiet for long periods of time. While a child who is less active may take more time to finish things and often can sit still and listen in school. For strength of expression, you need to ask yourself, how strongly does this child express feelings, wants, and opinions? Or do I have to guess what he is thinking? A child who is very expressive may yell or cry over small things, may have trouble taking turns or letting other children choose games, and they are very good at talking you into things. While a child who is less expressive may be seen as an underachiever, can get pushed around by other children, but may also be calmer and more cooperative. One that I would like you to consider, especially because of transitions, is the ability to change. Ask yourself, how easily does this child accept change? What would happen if he needs to go to a new classroom or a new center? Is he friendly with new children? A child who enjoys change can wander off, likes to explore new places, easily meets and accepts new people, and can become bored with the same things. Where a child who prefers the familiar is shy with new people and places, likes his toys, his classroom, and his teacher to stay the same, and needs more time to deal with changes in their routines. Sensitivity to senses. Ask yourself, how sensitive is this child to light, smells, sounds, and touching? What happens if there's a loud noise in the classroom? How does this child react? A sensitive child to senses becomes fussy if there's loud noises or bright lights, learns better by seeing, touching, and using all of the senses, and may be cuddly and sometimes clingy. Where a child who's less sensitive to senses is not interested in hugging and touching, enjoys bright light and loud music, and can even sleep through the noise and light during nap time. Persistence. You need to ask yourself, how does this child stick with and complete a task? Will he or she sit down and do one thing until he's finished? Or does he start something and move on in the middle of it when it's too difficult? A child who is persistent might have trouble taking no for an answer and is often considered stubborn, but usually does well in school. While a child who is less persistent may have trouble finishing things and may give up on toys and tasks that are too complicated or uninteresting. Need for physical routine. Ask yourself, how much routine does this child need? Does he like to do the same things at the same time every day? What would happen if we made a change in the classroom routine? A child who likes physical routine usually likes to do things at the same time every day. He has a favorite toy and a favorite cup and can get upset when the day doesn't go the same. While a child who likes variety in the physical routine doesn't mind you changing things, enjoys the difference, and may not notice small changes during the day. Awareness of feeling. We're almost done. Ask yourself, how aware is this child of feelings and emotions? Can this child tell me what he or she is feeling? When someone is sad or hurt, does this child notice and seem concerned about what the child is feeling? A child who is aware of feelings is very caring and sympathetic to others and can use words to tell you how he feels. While a child who is less aware of feelings may not know when he or why someone is upset and can act angry instead of sad or hurt. Distractibility. Ask yourself, how does this child pay attention? Does he stop when he's doing things often? What happens if a sudden noise or someone walks into the room? A child who is more focused completes tasks easily, may be unaware of danger, learns quickly, but may not hear you when you call his name out. While a child who is easily distracted has trouble finishing things and is easily sidetracked from what he is doing when people enter the room. Their usual mood. Now we come to the last temperament. The usual mood. You need to ask yourself, what is the mood of this child most of the time? Does he laugh or smile a lot? Is he usually positive or negative when things happen? Does he usually seem serious? A child who is usually in a happy mood makes friends easy and might not know how to act when serious things happen. A child who is usually serious has a harder time having fun and may seem to be unhappy or having problems when he does not. A child who is usually less positive might have trouble keeping friends and become sad and frustrated easily. So when we consider healthy brain development, not only is it important for you to know about how the brain functions, but also how the brain is acquiring their information, in considering the children's 3 basic learning styles, which were visual, auditory, and kinesthetic, and the different temperaments that a child has. Let's conclude this with the last video clip. Remember that we together shape the world, one child, one mind at a time. Children are our future, and we must take care of them with maximum effort. I want to thank you all for everything you do for children and families, and for taking part in this presentation. At this time, I'd like you to answer any quiz questions that you have and take a brief break before the next session.